Alright guys, welcome back to another edition of the ICU curriculum. Today we are going to be talking about pain management and sedation in the ICU. Again, these are designed to be kind of complements to your bedside teaching, so without further ado, let's get going. Okay, so why is this important? So it seems like there is a growing sea of literature that seems to confirm that there is an increased morbidity and mortality even associated with pain, agitation, and delirium in the ICU. So as a result, there's this kind of ongoing effort to help ICU providers, I guess, first prevent and then second treat these things in ICU patients. So today's goals, quickly, we're going to review some of the guidelines for pain, agitation, delirium in the ICU. You'll see it referred to often as PAD. We're going to discuss some methods to help assess these topics, and we're going to discuss some treatment methods and prevention for PAD. All right. So we're going to be leaning heavily on the 2013 Society of Critical Care Medicine guidelines here. This is the citation. If you want to go to the article, I would suggest taking a look at it. There's a nice executive summary, I believe. Okay, so we're going to start with pain. Most critically ill patients will experience pain sometimes in their ICU, and there's lots of different things in the ICU that we do to cause people pain. One of the most common causes of pain is just having an intratracheal tube in place. And the problem is that oftentimes these ICU patients are unable to self-report their pain. You can look here. This is a little citation on pain, with secondary to the endotracheal tube. So what does that do? So here's some acute and some chronic consequences of pain in the ICU. So the acute issues are they can prevent mobilization, ventilator weaning, they can interfere with sleep. This kind of increasing catecholamine surge can cause some other things too, theoretically. Impaired wound healing, muscle, you can see here, muscle catabolism, tissue hypoxemia, they can impair the immune system and, some of the, immune system activities. And then there's some more chronic consequences of pain. We kind of see these when patients come back to see us in clinic, basically on their first follow-up from being discharged. So they can have chronic pain, PTSD, it can decrease the quality of their life. So how do we assess pain in the ICU? Well, obviously, self-reporting or self-assessment would be the ideal way. Now, I think we've all seen these smiley, frowny faces here in the ICU. This thing here is the numeric pain scale. You can see here what's mild, moderate, and severe pain. This is the CPOT, or the Critical Care Pain Observation Tool. Now, I'm not going to go through these. I just want, in detail, I just wanted you guys to be aware and have an example of what these things look like and get an idea on what a CPOT score is. So, judging by the CPOT score, it ranges from a 0 to a 10. Your pain goal is basically less than 3 or less. Anything greater than 3 is considered significant pain. And we didn't specifically say this, but assuming you can't speak or tell the physician or the nurse that you're in pain, we have options on what we can use. And it seems like statistically, behavioral pain scales are actually better than just looking at patients' vitals alone, because things can be confusing. There's things that can increase your heart rate that don't have to do with pain in the ICU. And if you go by a behavioral pain scale, it actually improves the amount of analgesics you use, the number of days on the mechanical ventilation, and even sometimes ICU stay. Here's another behavioral pain scale that we can look at here, the BPS itself. I'll just kind of let you look at that real quick. You can pause and come back to it. Okay, so treatment of pain in the ICU. I put this slide in here. This is like a quick little summary of what you would actually treat for. So if you have an NRS score of greater than or equal to 4, that's the numeric scale. The BPS greater than 5, or CPOT greater than or equal to 3, you would consider treating. And we kind of divide treatment into this kind of category of non-neuropathic pain and the neuropathic pain, because we treat them a little differently. You can see here, in the non-neuropathic pain, opioids are the first line therapy. Plus, you can add some non-opioids like acetaminophen or NSAIDs. And in the neuropathic pain category, we use things like gabapentin, Neurontin, or carbamazepine plus IV opioids if needed. In theory, all IV opioids titrated to similar, endpoints are in general equally effective. And the other thing that is always a little complicated is considering patients' home pain regimen, particularly people who are polysubstance abusers or people who have, very extensive pain medication regimens at home. That makes things a little bit more difficult. So moving on to agitation. So there are multiple studies that demonstrate a negative consequence to prolonged and deep sedation, and in general would seem to benefit lighter sedation. This is the idea of you don't really just want to keep your patients snowed in the ICU. You want them to be able to wake up and communicate with you. And you can also see here that the use of sedation scales and protocols designed to kind of minimize sedation are actually associated with improved outcomes. Shorter length of stay in the ICU and in the hospital, a decreased duration of mechanical ventilation, and decreased incidence of delirium, and this kind of long-term cognitive dysfunction. So this is a slide about the awakening trial, or we're going to call it the ABC trial. This here, awakening and breathing control trial, where they basically looked at a group of people who got a spontaneous breathing trial, and then another group that got a sedation holiday and the SBT. And you can see here it's pretty clear that the group that had the daily awakening and the spontaneous breathing trial did a little bit better than the other group. This is duration of days on the ventilator and then the ICU stays. So they basically woke up and got off the vent a little bit faster and got out of the ICU a little bit quicker. So here are some of the different assessment tools that you can use to kind of rate sedation in the ICU. This is one of the really commonly used RASS scores here, RASS. You can see here in a goal RASS, what you would target, you would want light sedation from either a +1, a 0, or a -1. That would be kind of your ideal range. And then here is the SAS, or the Riker Sedation Agitation Scale. Again, you're kind of shooting for in the middle of the road, calm and cooperative, easily awakens, follows commands. So how do you treat agitation in the ICU? And again, we're referring heavily on the 2013 Society of Critical Care Medicine guidelines. So non-benzodiazepines are basically your first line. Those would be things like propofol or dexmedetomidine. Now we do have this little asterisk over here. So when would you want to use benzodiazepines, things like Versed, Ativan, or Valium? These are basically reserved for people who have alcohol withdrawal or other benzo withdrawal, seizures. If you need someone to be deeply sedated, so those would be things like if they have severe ARDS and you have them sedated, paralyzed, and prone. And then sometimes, as adjunct therapy when other things don't work. Other things being propofol or dexmedetomidine. So what are some different treatments? We kind of said before, propofol and dexmedetomidine are kind of your go-to guys. So propofol is highly lipophilic. It's got a quick on and quick off set. It's less amnestic than a light sedation versus benzos. It does have a 10% lipid component to it. So that because of that, you have to worry about allergies to eggs or soybean. Hypertriglyceridemia can lead to pancreatitis, and then there's these other issues like propofol infusion syndrome, where you get an unexplained lactic acidosis, liver and renal failure. This is another thing that you can get with propofol. It can make your urine turn green. It is a benign condition, something that your nurse may call you about, but it's nothing to be worried about. Now, dexmedetomidine is basically an alpha-2 agonist. It's very similar to clonidine, but it has more of a sedating effect. It has a slower onset of action than propofol, but the good thing about this is there's no respiratory drive. One of the bad things is it can cause a bradycardia and hypotension, so not good to use in someone who's already borderline bradycardic as it is. This was just a little quick chart I wanted to include because it has a little comparison between propofol, dexmedetomidine, and some of those other benzos that we talked about. I'm not going to go through in detail. You can pause it and look at it, but at least you get kind of an idea on the half-life and the elimination in half-life, particularly paying attention to things that have active metabolites like Valium and midazolam or Versed here. So something to keep in mind if someone has renal or liver failure when you're trying to choose which sedating medication you might want to use. We're going to move on to delirium now. So up here, we can see that delirium in the ICU is definitely associated with some poor outcomes, increased mortality, increased length of stay. In ICU stay, you can develop a post-ICU cognitive impairment, and as a result of these other things, it can increase the cost of your care. Now, these are some of the risk factors that we have found to be associated with delirium. So you can see alcoholism, hypertension. If someone was in a kind of a coma or profound sedation while they're in the ICU, how sick they were, and if they had any pre-existing dementia. This is one of the delirium assessment tools. We call it the CAM ICU. And basically you have, again, I'm not going to go through this in long detail, but what you end up getting is a series of checks. And if I'll say you fail, but if you score for them, you become CAM positive, which means delirium is present, versus cam negative, where there is no delirium. Here's another checklist here. This is the intensive care delirium screening checklist. You can see down here there's kind of a scoring system at the bottom that kind of gives you an idea on if they have a low score, they don't have enough to be qualified as delirium, and if you have a score of greater than or equal to 4, you have delirium. So how do we treat delirium? Well, the first step is prevention. So that's things like early mobilization, promoting the normal sleep and wake cycles. That's closing your blinds at night, turning off the TV, getting the families to leave, trying to not interrupt them to sleep, and then during the daytime, lights up, in a chair, up, moving around. Then you can turn the TV on. The other thing you want to make sure is you want to restart the baseline psych meds. So the treatment, like we just said, the first thing you're going to want to do is you're going to reorient the patients. Familiar surroundings, make sure you have hearing aids, glasses on, even dentures if they can do that. You want to use, well, this is interesting, atypical antipsychotics may reduce the duration of delirium. It's not really clear that Haldol does that, so we use Haldol a lot for delirium, but the evidence is not super rock solid. You definitely want to avoid antipsychotics if there's a risk for torsades. So if they have a prolonged QT, history of arrhythmias, or other meds that prolong QT, things like there's some anti-seizure medicines or like things like Levaquin. And then, again, recommend dexmedetomidine for sedation to treat delirium, not related to alcohol or benzo withdrawal. So that's kind of one of the first-line medications to help treat this delirium. So this is just another quick slide taken again from those 2013 kind of guidelines. It's supposed to give you, this is a kind of a quick summary that should help you quickly figure out how to assess, treat, and prevent both pain, agitation, and delirium. Basically what we just talked about, but maybe this could be a quick reference for you if you know you're out and you don't want to go through the whole lecture, you just want to look at some little quick summary again. Again, keys being recommending light sedation, daily interruptions. Recommending analgesia first, sedation in ventilated patients, recommending promoting sleep in the ICU. So those are, again, just it's a quick review over some of these topics. The idea was to at least get it out there so you can see the different scoring systems, what is a good score, what is a bad score, what in general would be the treatments for these things, comparing and contrasting some of the agents that you might use to treat them, as well as other non-pharmacological techniques that you might use to treat things like delirium, for instance. Well, I hope this stimulates a little bit of discussion with you and your attending while you're out on rounds. So if you have any questions, it would be a good opportunity to ask them, particularly as you're weaning sedation and trying to wake people up as to kind of get them off the ventilator. All right, good luck out there, guys. Take care.